Good morning, everybody. Welcome to our session today, thinking about all things neighbourhood health and estate. Just a few practical things before we get started and I introduce our fantastic panel. Please submit your question and answers using the Q&A tab, which should be at the top of your screen. You can vote for your favourite questions by upvoting them using the upwards arrow next to each question. We really hope you've had the opportunity to visit our resources provided in your joining instructions. There's some useful stuff there related to the topics we're going to discuss today. I think neighbourhood health is just at such a critical point at the moment. It seems to be the answer for everything. We are going to focus on one of the really critical pieces of that whole debate about neighbourhood health, and that's estate. I mean, we know that physical and environment does underpin everything we do, from supporting clinical teams to ensuring patients have access to safe and modern facilities. That's despite the shift to digital. We're always going to need some really excellent estates. Today we've got a panel who bring perspectives from national strategy, from local delivery and system integration. Some of them, they've all got really good practical experience, and our aim is to explore with them how we can work collaboratively to make estates more proactive and sustainable, how we can deliver estate, how we can tweak our estate to really deliver good quality neighbourhood health and overcome some of those barriers that I'm sure that everybody has been facing. I really want to encourage some open discussion on the challenges and the innovations, and hopefully you'll be able to have a little bit more of an understanding about how to turn your vision locally for estate into reality by hearing from our panelists about all the challenges that they've overcome themselves. So can I ask our panel, please, just to take a moment to introduce themselves and tell us who you are and where you come from? I'll start with Karina.
Hi, my name's Karina Dare. I work for NHS Property Services in the Estate Strategy team and with the focus on primary care and community.
Thank you. Sarah.
My name's Sarah Herdman. I am a business manager for 2GP surgeries and a non-clinical director for a primary care network. And currently we have a neighbourhood teams building, if you'd like, that's just been developed in Chiswick.
Thank you. Lisa.
Hello, I'm Lisa Pope. I'm the Deputy Place Director for North Yorkshire for the ICB, and I'm the Programme Director for the flagship Catterick Integrated Care Centre.
Thank you. And finally, Frances.
Hi, thanks. I'm Frances Schmocker. I work for West Kent Health and Care Partnership, one of the neighbourhood teams for Kent and Medway ICB, hosted by Mason and Tunbridge Wells. And I am currently working on some estates work for integrated neighbourhood teams in the Maidstone area.
Thanks. As you can see, we've got a really excellent panel here covering a whole load of different perspectives. We're going to have a conversation for about 20-30 minutes, thinking between us and asking some questions. So hopefully that will give you a really good flavour of the kind of things the panel are really expert in. If during that time you can submit your Q&As, and then we'll move over to live audience Q&A as we go through. But the first question I want to ask, and I'm going to start with Karina, but is to say, what are the benefits of optimising what you've got already to really support neighbourhood health? We know although there's going to be more neighbourhood health centres built, the government are committing to building neighbourhood health centres. That's going to take a long time, and we need to deliver neighbourhood health relatively quickly. So what, in your experience, has been some of the benefits?
I think you've picked up some of those points, Vicky. Really, the benefit of using the existing estate is that it's there already. It might need some adaptation. It might need different approaches to how you're going to use it collectively or who's in the space, but it has the advantage of being an existing building. And it might be an existing building in the local authority's portfolio, or it might be a voluntary sector building, or it might be a GP surgery or a health centre. But you can then look at what you've got and how you might want to use it differently, and that's much, much quicker than a new build in our experience. And the other advantage I would suggest is that there's a lot of NHS buildings spread right across the country, and although there'll be some new money, that won't meet the requirements of everyone. So we've got an existing portfolio and we need to think carefully about how we make use of that.
Thanks, Karina. Sarah, talk a bit about, tell us a bit about what you've been doing and some of the benefits you've had of using your estate and adapting it to support neighbourhood health.
So I think, just to reiterate, we did get a new build at the end of it, but the start of it was about adapting what we already had. So we needed to look at what we wanted to bring in. So what exactly do you understand from a neighbourhood working group, an integrated team? Who needs space? What is that space? We go bold, you go very bold, and then you have to bring it down to a little bit of reality, because you can't have everything and you can't fit everything in. But new ways of working sounds very exotic, but I think breaking it down into simple areas of what you want and what you need, and then actually communicating with everybody. So the communication, I think, is the key. Speak to everyone, and that includes your patients, that includes all the people you want to move in that building or come through that building in any way. You need to communicate out, what do they expect, what do they want, and not necessarily a new build. People like they like where they know. So sometimes just developing what you've already got means that people know where that base is and they're familiar with it. A lick of paint is nice, but it isn't always the key to what people want. It's about the service you're going to deliver out of there. So I just think communication was the biggest key, and then just a bit of a map about how you're going to deliver it and what's your timescales. And what else is out there that you don't need to reinvent the wheel. I think those were the key things for us.
Sarah, I'm going to come back to you in a bit actually to talk about the experience that you had with
Yep.
working with patients, about how
Yep.
understanding what they wanted, because I know that's something that you've thought a lot about. But Francis, what have you been finding in your area about using existing estate?
Well, estates was a new area dedicated to the health and care partnerships, and actually, I think that gave us a good opportunity to really look at and refresh our understanding of what our estates were, and re-engage with our district council partners, with local authorities, and really understand that kind of broader estate piece. And the goal for what we're working on at the moment is to really have a single integrated neighbourhood hub, but to go through that process, we actually had a really good look at current estates, and that's given us a rethink on a staged approach to addressing some of our current problems. We have issues with primary care. We know some of our buildings are not fit for purpose, and we want to future-proof in terms of our population growth. And the last sort of 18 months has really given us a strategy that allows a phased approach to answering some of those problems, and it's been really positive. Actually, it's meant that we've had really excellent engagement between clinicians and estates people as well, because obviously you're coming with two different approaches and aims from those different groups. And it's been a positive process.
Great. Thanks, Francis. And Lisa, you've got a lovely new build estate. I mean, some new build estate, but what have you learned about how you might apply some of those principles to adapting the other estate that you have?
So yes, Becky, you're right. We do have a multi-million pound new build. We're very fortunate in that. But I think that we're now using the model that we've developed at the Catterick Integrated Care Centre to roll out our model of neighbourhood health across North Yorkshire. And in some areas, that means utilising estates. So, for example, in Ripon, we're currently moving services out of the community hospital there and out of GP practices into the leisure centre, which is owned by the local authority, and creating a hub there. But equally, we're also creating virtual hubs where we actually don't need a building. It's about a way of working and the model that we've established. But the CICC is our blueprint, and is the place that we have established those ways of working and piloted them and tested them. And I think really key to that has been the relationships that Karina and I have established over 10 years, which is a very long time, but I wouldn't perhaps advocate taking our time frame, although working between the NHS and the MOD, it has taken that long to get us to where we need to be. But those relationships have been absolutely key to really enabling and creating that trust for teams to work together in a way that's safe, and creating their own environment. So even if we didn't have our lovely new build, them having that trust together and creating their own ethos as an integrated team has been invaluable, and that's what we're now rolling out.
Thanks very much. So I'm really keen to hear a bit about a little bit more about how you've gone about doing the stuff you've done, and we've heard a bit about Sarah's conversations with patients around co-production, about thinking about what the model is that you want to look at, and I know there's some real practical issues, aren't there, about how you get around adapting buildings using this sometimes very old stock that we've got, and how you go about doing that. So tell me a little bit, and I'm going to come to Sarah first, but I'm going to ask a little bit about what were some of the barriers that you came across in adapting your existing buildings or overcoming them, but also particularly about how you've really understood what it is that your patients want from what they want from the services.
So I would say, I've always said, who owns the project? So who's involved in your project? Who are the owners for various areas? So who owns the building? Who's going to lead on things? You can very quickly work out who's best to lead on certain areas. But one of the biggest things was patient engagement. I think because I'm from a primary care level, patients, you have a view of what a patient wants, and actually then when you talk to them, they have a completely different view of what they expect when they come to one of these environments. So even down to the simplistic things like the signs on the toilets, or the colour of doors, or the colour of walls, they seem to be the last things you think about, but actually they mean a big thing to the patients when they enter an environment. So actually having local engagement with them, lots of, literally sitting in rooms and having conversations with them, actually meant that there was lots of things we didn't need to do. We thought we had these massive things we needed to achieve, but actually they just wanted some simplistic elements. But the main thing for them was the amount of the care they were going to receive. So what is in it for me as a patient? If you're going to give me a new building or you're going to use an old building, what's in it for me if I'm coming to that environment? Am I going to get better care, more quality, more choice? So I think that was a big thing, was about engaging with them about what their wants and needs were, and then talking to our secondary care colleagues and our community colleagues about what they wanted in that building and what they could offer and what their requirements were. And you then start to get a good picture of what you're trying to achieve, along with the strategy, which is local health and health nearer to care, nearer to home. You can start to map that together quite nicely. It's a bit of a dodgy jigsaw at the start, but actually it starts to come together quite nicely when you get everybody on board. So I think that was really enlightening. I think actually just literally having those conversations, because you're quite fearful at the start of what you're going to be told, but actually it was really quite cathartic towards the end, to actually get everybody speaking openly about how everyone could get involved and engaged in it.
Brilliant. Thank you. Lisa, can you tell us a little bit about your experience, particularly with the leisure centre? Because I think working cross-agency must have provided its own challenges. And I know the MOD in itself for the new build also had its challenges. But tell us a bit about how you've built those relationships so you can work cross-agency.
So with regards to Britain and the leisure centre, I suppose I'm fortunate and supported by Karina as well, that we've both been in the system a long time. So we know lots of people now, and we've established those relationships over a long time. But I think even if you don't have that privilege of being in a system for a long time, it's going back to the basics. It's selling the vision. It's understanding what it is that other people need in the system. So, for example, our GPs are in a beautiful repurposed Victorian townhouse that no longer lends itself to delivery of modern primary care. So they really struggle with that. So that's their driving force, is how do they get to an estate that is more accessible and more usable for them. The hospital, again, is a beautiful old building, but doesn't necessarily lend itself to modern healthcare delivery. So it's about understanding the drivers, I think, of the system partners and what brings them to the table in order to be able to develop a solution that works for everybody. And likewise for our local authority colleagues, whilst they own the leisure centre and therefore have the estate resource, they're looking at delivering as much of a holistic care offer as they possibly can. So it chimes with their JSNA, it chimes with their strategy. So it's about bringing everybody together and around the table as early as possible, I would say, and really understanding what it is that drives people to be there, but also what are their barriers, whether it's ownership of a building, whether it's kind of autonomy in terms of decision making, so that you get all of that out on the table really early and kind of shine a light on those things that perhaps would be a bit unpalatable to talk about if you didn't have those relationships, or you didn't create that opportunity. And I think again with the MOD, I mean it's an ever-changing beast. So although Karina and I have both been around this system a long time, the MOD historically changed roles roughly every couple of years, so you don't generally have the same people around the table. So again, it's about understanding people's drive, establishing those relationships quickly, and understanding where they face challenges and perhaps where we can help to address them, but also how they can help us, and you create that reciprocity and mutual trust that then enables the delivery of something different.
Thank you. Karina, what's been your role in helping overcome some of these barriers, and tell us a bit more about what you've been working on?
I'm probably going to take a slightly broader comment, I guess, because my role, obviously, as an estates professional, is to have some of those difficult conversations about things like money and funding, and how's it going to be paid for, and who's going to pay the bill, which is always challenging. But in my experience, getting those conversations out very early is important, because you can run away with a really good idea and a long list of what you would like to do. A bit like Sarah said, then reality bites, and you need to chisel that down to what you can afford and what you can deliver and fund if you want to make changes. So I think my experience is to try and have those conversations at the beginning. I agree with Lisa that it's understanding what people's drivers are and what their parameters are, what they're trying to achieve. If you can get those things aligned in the beginning, it's helpful, because it will be challenging. If you're going to make any change to the estate, whether it's a new build or a reconfiguration or just a small investment, it disrupts people's day job. It requires lots of extra effort, and there will be issues along the way that you need to unpick. So relationships, absolutely, clarity about money. And then there's the nice stuff about, can we redesign these rooms and make them modern and clean and have good clinical IPCs and make the building look nice for the people working in it. Actually, that's probably the easier part once you've got the other things resolved. So my experience is, a lot of communicating at the beginning about the fundamentals to get everybody on the same page, and understanding the limitations of what is possible at the beginning.
Thanks, Karina. And Francis, your take on this, and also tell us a little bit about the size of the scale that you're working at. I can see that's coming up quite a lot in the questions, but I think it'd be really interesting to hear about how you're working and what's the kind of model that you're trying to deliver down in your area.
To start at the beginning, essentially we had a big problem with lack of primary care provision in our Maidstone area, and it's our area of highest deprivation. So it's been identified within our estate strategy as a priority area. So we'd commissioned NHS Property Services to do some work for us to identify some estate solutions to this, and then it was tied in with the integrated neighbourhood team development. Through the work that NHS Property Services have done, they have identified a building. So we're looking at a development through Maidstone Borough Council of, I think, 2,000 square metres. So it's quite a large space, of which some of it will be primary care, some of it will be community services, some of it possibly acute, possibly mental health, but then we want provision for a range of other services. And actually, a lot of what everybody is saying absolutely rang true. NHS Property Services were extremely helpful in that engagement bit, early doors with what is it that is the current problem that we need to solve, and where do we want to get to, and bringing everybody together to come up with that kind of schedule of accommodation. That communication bit was absolutely critical. We're currently at the stage where we're taking our strategic outline case to the ICB exec for approval, so the money bit also rings true, that there's been quite a bit of, this is what we would like, this is what we need to future proof, but actually there's been lots of managing expectations, and I think that's really critical of making this a successful program and getting it through to approval. And actually the engagement bit, now we're starting to pull in the kind of the strategy leads from our organisations, provider organisations, because they absolutely need to be on board with this. So it's about getting everybody engaged in that integrated element, and then signing up and putting their money, their hand in their pockets for the money, because we can't do it without them. It has to be everybody involved. But NHS or property services were also really helpful in just looking at a range of different funding models. And actually, within our team, we didn't necessarily have that skill set, and it's been so useful to have that support from NHS property services to really understand what the options are for these type of integrated hubs. And it doesn't have to be the normal funding model. There are other ways of looking at it, and that's been really helpful for us to consider how we're going to get it through the next kind of funding rounds and to final agreement.
And what kind of population are you covering, Frances?
So it's Mason Central, so you're looking at about 40 to 50,000 altogether, but you're looking at quite a big population increase over the next 15 years, so another 10 to 12,000 coming in over the next 10 to 15 years.
Brilliant, thank you. And Lisa, what about you in Ripon and Catterick? What kind of populations do you cover?
For Catterick, it's about 30,000, and again, we're looking at an increase of 10 to 15,000 over the next 10 years. Some of that will be military rebasing, as Catterick is Europe's biggest super garrison, but also we have a sizable amount of new build housing going up all around the garrison site.
Great, thank you. And Sarah, you tell me a little bit. I know yours is a primary care based one. What's your kind of population?
50,000 with a projected increase of around 8 to 12.
That's really helpful, everybody. Thank you. I think it just gives people a sense of the kind of scale of area that you're looking to tackle. But I'm going to ask you now for the kind of the fun bit, which is what are your creative examples of how you use your physical space differently? So tell us a bit more about what it looks like. And Karina, I might just come to you to see if you can find some other examples for us from across the country. But Sarah, tell me a bit about what's the interesting bits of your system. What do you think is the bit that patients have appreciated that others might learn from?
So open space. We do lots of now, rather than this one-to-one scenario, we do lots of group session. So we have lots of community sessions in there. Seated ballets, quite popular. But we have lots of group sessions, group webinars, so people don't necessarily have to come on site now. So we'll do webinars and they can join that and cover things like ADHD, etc. Lots of the community services are now trying to run out of, we've got some space downstairs, they run lots of community services out of there. All our local patient engagement meetings are held out of the building now. So that's the community base. Acute settings, we have secondary care in there for outreach services. So they run breast pain clinics out of there. Small clinics rather than the large cardiology ones, but the small clinics for those small groups of patients. So they can come to us rather than having to go to the hospital. We have community services anyway, so your local MSK or podiatry services are all in there. And there's 3 GP surgeries in there covering roughly 25,000 patients. So there's quite a lot of footfall through the building. But the surgeries have slightly changed some of their systems. So for the surgery I run in there, the GPs don't own a room. You don't have a clinical room. If you're seeing patients, you go into a clinical space, but if you are not, you come out and you go into what we call our remote working booths. So you have a computer and a phone in there, but you go in there and work, and it allows us to use the space for another clinical session, which could be anything. So if we need a clinical space, it allows us that flexibility to move people around, so that actually one room is probably catering for 3 or 4 different clinicians in one day. So yeah, so that's some of the, and the patients have found that they don't have to come in as much because we're able to give them a little bit of remote work. And I think because of the frailty work we do as well, we try to gather those patients up so they're coming in a more structured way. So they're not coming in 4 or 5 times for things, they're coming in maybe once or twice. So we try to organise our systems in our practice to help with that. So if they're coming for podiatry, can we work around their podiatry appointment and get them in for everything else? So it's kind of a bit broader, and secondary care are coming on more and more now to come out. But I think it's slow progress for them because they have to shift their clinics around a little bit more. But yeah, that's mostly some of the work we've done. Yes, just consideration of what the patients wanted downstairs. So all the surgeries are on the first floor and up. Downstairs is all community.
Lovely, thanks, Sarah. Lisa, tell me a bit about the interesting things around the builds that you've made. What are the kind of creative examples you've had about using physical space? So, Lisa, you're on mute.
Apologies for the school girl error. It was interesting to hear Sarah actually, because we're taking much the same approach. So community space as much as possible on the ground floor, and primary care up on the first floor. I think we fought really hard to keep an atrium space in the integrated care centre, so that we could have that kind of free flowing fluid space that could be owned and used as a community asset. So that will have pop-up clinics in it. But also it's for the community to decide how they want to use that space and what sort of supportive environments they want to create there. So we've had all sorts of requests for use of that space already, from people who'd like to come and share the history of the garrison, to having kind of mum and baby groups or parent and baby groups practicing in there. We'll have a community cafe in there so people can meet and have conversations. We've got some kind of low-level mental health intervention clinics that will be able to be held in that space. So really, I guess, talking to the patients and then understanding what kind of space we need to create to facilitate that community ownership of the asset, but also not being too restrictive on how that space is used, so that people feel that they can kind of create the interventions and the groups that they want to use together. I think in the leisure centre, we've really made the most of using the space that's already there. So things like cardiac rehab happens in the gym, and we've got a space to be able to do that. There's a pool there so that we can do aquatic rehab. There's open space for things to happen as well. So I think it's a real balance in being open and fluid about how the space can be used and allowing the community to create what they need, versus obviously getting the value for money of using the space in the most effective way. But I think we've probably taken the same approach to balancing it as Sarah has in her area.
Lovely, thanks, Lisa. And Francis, what are the ways that you think you're going to be working creatively in Maidstone to deliver this?
So through the engagement bit, actually, the one thing that really came out from all our providers and the people potentially who are going to be engaged in the project was flexible space. So we're very much at the developmental stage. So at this stage, absolutely not tying down what that space is, which I think really that's similar to what Lisa and Sarah are saying about having different options. So there will be primary care space and there will be community services space, but actually making sure that we can put in the digital element that's required. So there's space for people to have remote working, and an option for us to be able to change those services over time as our service model becomes more embedded. We want to be able to flex who comes in and comes out of that building, and that message came up again and again, and I think that's a bit lessons learned from some of the other new builds and changes in estates that we've put in other areas across Kent. But also the next step for us is the patient engagement bit, which is critical, but also really working with our staff. I think sometimes we can forget actually what the staff ask is. This is where they have to be in every day. So the next steps are really to have a look at actually what their needs, because they understand as well as anybody what the patient wants and how they can deliver that in a comfortable space. So those are the kind of three big things. But also we were really keen to look at the environmental climate change element bit. So we're starting to work up some of those bits around what do we want to put in to make this as green as possible.
That's really helpful, thank you. I mean, I think there's so much creativity and so much experience we've got in the room. I'm going to start moving over to some of the questions that we're getting from the audience. I think we'll carry on this conversation just guided by what they are. Now, this is one for you, Karina. I think, to
Okay.
start with, but also for others to I'll start with you, but others will come in, which is, and by far and away the most popular question so far has been, did the panel encounter issues over who agrees to hold the lease and who agrees to fund the premises costs? And do you have any key lessons learned to share? I think this is the burning question that people have got right now. So I'll start with you, Karina.
So I think, yes, we recognise that the big question that neighbourhood health asks of the estate is, how do you have multi organisations using the space? How do you make sure that everybody feels that they're getting a fair and effective use of that space, and allocating costs appropriately? Probably there are examples which I'm stumbling a bit. I could give you an example of ACAM in York, where the GP Federation took the lead. So in that example, the GP Federation took the lead. They took the lease. There was some risk in that for them, but the ICB supported them to do that through shifting some funding. And they then had an agreement where we'd put in place an agreement that they could share that space, but also that they could do some license arrangements with other occupiers to come in. So they then managed, underneath their leasing arrangement, a series of other occupiers to come in that fit with their agenda. And actually that's changed a lot over time. So originally they had some ultrasound, they had wound care, they had diabetes service, and then they had services from each of the PCNs, because there were 3 PCNs in that locality. So they were all collectively using the building. But then over time, they've brought in a virtual frailty hub. They've brought in some work they're doing with the ambulance service, which were more back of office. So they've changed the building around to reflect that. But I think them taking that lead created flexibility to make those changes and do things as their service model evolved. And then most recently, they're developing a mental health hub in that same location, because it has a community cafe, it's well sited, and it provides that option for that part of the city. So I think where you've got a lead organisation who are prepared to do that, then that unlocks some of those conversations. And I think that is one of the challenges of neighbourhood health, is how we make the operational management of the building as flexible as possible. I guess the other alternative would be to go through more of a sessional booking platform like Open Space that we use, which we are doing on the scheme at Catterick that Lisa's been talking about, where there's some dedicated space for the general practice, but then there's a space where lots and lots of different service providers will be coming in and using those rooms sessionally on an as-needed basis. So that then really drives your utilisation. Most NHS buildings are only utilised about 50%. Not necessarily GP practice, I would say. Some GP practices are sweating it a lot more than that, but a lot of health centres and other facilities, people think they're busy, but they're not. When you put sensors in, you actually see who's using the rooms and how frequently. About 50% is what we're seeing. So to drive that utilisation up even to 60 or 70% massively increases your opportunity to get loads of services in there that are local to your patients and the people that you want to serve.
That's really helpful. Thank you. So Lisa, what was the contracting conversations and the risk sharing in your schemes?
I'm chuckling because they are resolved, but they felt like they went on for forever, and really it was Karina that held the ring on that. I think complicated is probably understating it, between the NHS and the MOD, both of which are huge organisations with their own rules, often which don't necessarily time with one another. So Karina can talk more about the actual contracting vehicle that we've used, but I think in the end, what was stronger for us was that the MOD already owned the site. Therefore, they made an agreement to allow us to use that site, and we collectively built the facility that we now have, and we take a share of that as the NHS, and they take a share of that as the MOD, which is not a kind of 50-50 split, but is proportionate to the utilisation of it. And then Karina and colleagues designed the contract that would enable us to kind of follow that footprint. I think we don't open until April of next year. So obviously we'll see how it works once we're actually in the building and it is actually working. But it's something that, again, I think ultimately was achieved not by any of the regulations or by the rules, but by the fact that we were all around the table and thrashing it out for as long as it took, really. Corinne, would you add anything there?
I'd probably just say that one of the things I think will make that work is actually that there's sort of an agreed set of principles about how that's going to work, how that space and how they're going to manage that collectively between the organisations. Because I think it's very easy to draw a red line on a plan and say, that's your space. But actually, when you start talking about how you're going to share space, how you're going to collectively deliver services, you need those principles agreed, because you need to be able to come back to those later when things don't go as well as everyone might like. If you don't have that touch point, the arguments about the difficult things can really derail what you're trying to achieve.
Really helpful, thank you. Sarah or Francis, do either of you got particular examples of how you've overcome these issues around lease and who owns and who's going to fund the costs?
I think if I was the GP surgery side of it, it was first most people couldn't find their lease, which was quite interesting, because we had to leave an old building and move off site for 2 years. I think it was important for everyone to understand what a lease meant and also what space they were using. So lots of people didn't understand that they pay for shares of corridors because your patients walk down corridors. So it was making sure everybody understood the whole concept of what their space was against shared space. We had community providers in the building, so they obviously have their own lease for their space. And we have we have Mental Health Trust in there as well. So they've already got their own lease, but the space downstairs is on open space. And those that are charities or have no funding can apply to use that space freely. What we did do is get someone to project lead on our community providers. We didn't realise how many there were out there, free services to patients. So bringing them on board and actually having someone liaise with them directly and get them all on board has allowed them to come into the building, but they don't actually pay for the space they use downstairs because they qualify to use it free. So we have a similar thing where we have sensors on the room, so we know how many times they're being used. And also the PCN pays for space that the PCN uses. So we house the PCN staff on site in our building. And they use the rooms, but for the services they deliver, and there is a reimbursement obviously because they are earning money for the PCN, that money is dedicated to pay for the space that they are utilising. So the PCN itself generates the income to pay for their space, but that contract is held by the PCN, so that lease is held by the PCN. I just think get round the table and really understand what you're taking on. And if you're going from an old build to a new build, what the differences can be. It can be very exciting to take on extra rooms, but they come at extra cost. Yes. So just think about that. And do you really need those 9 rooms? Can you get away with 7 rooms and actually bring your costs down? So it's actually really looking at yourself if you're going to be in the property or whoever's going to be in there and about what they actually need. So those were the things for us.
Thanks. I think if I've heard anything here, it's get everybody round the table and start thrashing this out early, and then try to reach out for other expertise to support as well. I'm going to pivot just a little bit. This has flown by this time already, but I want to talk a bit about culture, because that question has been coming in. A question here about just displacing acute services into community settings isn't going to deliver neighbourhood health, and there needs to be a culture shift to ensure real change to what local people experience. And I wondered, Francis, I'm sure that's something you've been thinking about down in Maidstone. Do you want to have some reflections on that?
Absolutely, and actually I would say that's come from 2 sides, from primary care all the way through to acute, that it's been really hard to change the culture around what we mean by integrated provision, how integrated provision will meet the needs of our population and the growth. And it's been really difficult to get them to integration has been a discussion that's been around for a long time. It's not the first time we're having these discussions. It's not the first time we're having discussions about integrated estates. And actually, it's been a process of really careful engagement about what that space means and what it means to other people and how they might use that. And I think one of the things that we found was helpful was obviously embedding it in your population need and how services change, but also allowing some flexibility of our providers to use that space as they need it. So, for example, with acute, if we want them to deliver something in there, we've offered up some extra space because they have issues around health visiting or midwifery. So it's been that kind of a bit of a two-way conversation. So saying, we need this for you to deliver integrated neighbourhood health, and that will help you for X number of reasons, but also we're going to offer you up a bit of extra space to help solve some of your problems. And actually that's helped in terms of a hook, and then you can start to have a conversation about what else we need and why they need to be in. But it has been really difficult because you're at a time where budgets are really pressed, the acutes are looking to minimise their space. The initial conversation for us was no, we're not in a position to start to move set teams out, other than the ones that don't have space, but they might not meet the patient needs. So it has been definitely a two-way conversation, and offering a hook to start for us to be able to put in the bits that we need seems to be the most effective way of doing it.
That's helpful, thank you. Lisa, has that been a conversation you've been having?
Yeah, very definitely. I think the thing that probably makes the CICC different to other schemes that we've tried before and other attempts to bring the NHS and the MOD together on the Garrison site is the culture piece this time. So we started the organisational design piece probably 5 years ago now, so 5 years into our journey of trying to bring all of the services together. And the thing that makes the CICC different is that we're not co-locating with the MOD, which historically has happened elsewhere in the country. We are integrating, and it's a gigantic challenge because neither the NHS nor the MOD is homogenous in its own cultures. So bringing together our own houses and then bringing the two together in totality is an enormous challenge. But the way that we've done it is to do it through our clinical operating model by bringing providers and practitioners together, and that's led by a GP who works for us in the NHS and a GP who works in the MOD. They've created a team and then brought together the other teams around a clinical operating model and really worked through on a piece by piece basis. How can we work together? What can we add to each other in order to make our offer better for our patients? How do we make life easier for one another? What is it that makes our lives hard? What do we think will be the stumbling blocks? And really just working through understanding what each of the challenges and barriers are, but also what each of the value adds that we bring. But also just in the process of doing that, creating teams together by addressing that challenge, and also including our patients in those discussions. So really talking to people about what they need, about the barriers that they face in accessing care, and how they would like care to look in the future. And then again, bringing that to the clinicians so that really we're all addressing the same problem together. That in and of itself creates a culture that I would like to think in the future, once we're actually in the centre, that people feel first and foremost they are part of the CICC, and then their NHS, or then their MOD, and that it has its own organisational culture. And I'm really confident that we're very close to doing that now, although obviously when we open, the proof will be in the pudding.
Lovely, thank you. One of the questions that's come in, and it's something we've been talking a lot about at the fund recently, which is slightly pivoting, is around mental health. Mental health seems to be often seen very separately from neighbourhood health, which makes absolutely no sense. We talk about mental health services have had a very different experience and history around community services. But the question here, and I'll read it, is how do you think the drive for establishing neighbourhood health centres align with the parallel requirements for mental health 24/7 neighbourhood health centres? They need to serve different cohorts, they've got different requirements. Do we risk excluding mental health from these conversations? And I'm wondering whether any of you have been experiencing some of those conversations around mental health, or maybe that will be telling when we haven't. But Karina, I wonder if at Property Services, that's something you've been thinking about.
I don't know. I was going to say, I don't know if we've been thinking about it, but that's not actually what I mean. What I was going to say is the examples I've given actually do include mental health in those facilities, services. So certainly the ACOM example includes, was originally the base for mental health. It was a community unit for an elderly. It was an older person's inpatient unit that was converted to be used for the locality hub for all the services to come. And the mental health teams actually stayed in that facility. And now there's a combined community mental health hub to be delivered from the same location. So I don't see that there's necessarily any barrier to those things operating jointly, because actually the people who are using those services are in the community. So why would we create an artificial barrier to doing all of those same things in the same facility? And I would, Catterick as another example, has the local community mental health hub coming in and the military mental health services, and they will all be operating from the same facility. So in terms of a challenge around funding and how things are done, it may be an issue, but it would be worked through in the same way as all the other organisations and partners, I would have thought. So I don't perceive that there is any difference or should be any difference in how you deal with that in terms of neighbourhood health. But I'll bow to the others' greater experience in this probably.
That's really helpful. Thank you. Frances, have you had discussions about mental health?
So absolutely, and we have taken the approach that Karina's suggesting, where we wanted mental health in from the beginning. So they have been part of the engagement process right from the get-go, and are very much engaged now, and they are having their discussions about what their contributions are going to be to the site. So we didn't view them as any different to anybody else that we wanted to have within the facility, and we've engaged them from the beginning, and actually it's been very positive. Again, you know, they're talking about their community health and how they're transforming their services, so it sort of feels like it's all aligned and come together at the right time. But yes, we're not they absolutely are part of the neighbourhood health model, and we wouldn't want to leave them out, and they have been very engaged. So it's been a positive conversation on the whole.
Thanks very much, Frances. And I'm actually going to broaden this out, because I think there's been a lot of conversation here, unsurprisingly, about the voluntary and community sector. So we talk a lot about NHS services coming together. We talk about shifting stuff from hospitals and mental health. But and Sarah, you gave some great examples of opening up your service to the voluntary sector. But how have you been engaging I'm going to put this to most of you, I think, in with that wider, how have you known what's out there in the community? How have you gone about mapping those services and opening it up? Sarah, you talked about your project manager. I wondered whether you might just talk a little bit more about how you've gone about integrating the voluntary sector in your neighbourhood into that neighbourhood hub.
So we utilised some of the project money for the build. So we requested that some of the project money, so I think that was one of the things we were quite keen on at the start, was if there was some pots of money we could utilise for project work. So I would say one of the, and I'll come on to the community bit, but one of the things you don't realise is how much work is involved. So if it's your job to do this piece of work, then that's great. But if you're a service in the building, and you don't have a lead for this, so for a GP surgery, it'll be the practice manager or the lead GP. They're not funded to do it. So you're going to be doing that out of the goodness of your heart. So they can't then take on more work without some support. So what we quickly realised is if you wanted to utilise the services coming in and using the building, we needed someone to lead on that, because not everybody had the time to do it. So we engaged somebody to take on that work and allocated some project money from the build for them to take on engaging with what was out there. And quite quickly you find out you have no clue in relation to how many services are out there in your community being provided by people. And you know, we talk about the big ones like Age UK and all that, but there are some small groups who deliver services to 10 or 12 people a week that make a huge difference to that population. And once word gets out, more people wish to join. So we got someone to lead on it. They went out there and found as many as they could. We got them all together and discussed with them if the space was usable for them or what they needed. You know, did they want to come into the building? Because some of them are quite happy where they are. But what we did with that was we then engaged with how much space they needed and how often they needed it. And if they didn't want to come into the building, how could we advertise for them? So how could we support them with the community knowing that those services were available, just not on our site? We also engaged with the nearby leisure centre for exercise on referral, the sessions they ran down there. There was lots of things people just did not know about, or we didn't know. And we probably weren't referring people to it because we didn't know. So the lead for that, lovely guy called Andrew, spent lots of time and drinking lots of tea, he assured me, just talking to those groups about what they could offer, what they needed, and how they could support. And they were so enthusiastic to be part and parcel of it. And the patients really felt that, and the rest of the community felt that actually we'd taken on board the community element in that way. And when we designed, so we have a garden at the health centre, and when we designed that was based on it being utilised for the mental health services who are on our third floor and any patients who wish to be part of the gardening group. So little things came out of that we hadn't even thought of, which we then put into the project. So yeah, so that's what we did in leading forward with it.
Lovely, thank you. Lisa, have you been engaging around? I'm thinking about the Ripon, but and Catterick, but the other facilities that you've got.
Yeah, I think Catterick's probably a really good example actually, because the BCSE is literally front and centre in the atrium space in the building. So engaging with the BCSE particularly around the military, as you can imagine, is a huge challenge because there are so many charitable organisations that support both serving personnel, veterans and families. So actually just kind of understanding what's available in the market and who's around is a huge challenge, and it's something that changes very frequently as well. So that's probably a cautionary tale. I'd say we started thinking, well, we'll just establish a directory of services and then at least we know who's around, but actually that changes on a daily basis. So that's probably not a rabbit hole to go down. But I think just making the space free probably was the biggest thing that we could do, the atrium space. And whilst that took a lot of campaigning on mine and Karina's behalf to keep that space, charitable organisations having access to free space in the community that people will already be going to in order to go and get their doctor's appointments or go to the cafe or whatever it is that they are going there for, is hugely, hugely valuable. And then really bringing those BCSE organisations together with the patients to talk about what's currently in the market, what's already, as Sarah said, well provided for, that actually we just need to leave well alone because people are perfectly comfortable with it. But also what value could we add by having the CICC has been enormously valuable and has kind of created its own momentum to bring more BCSE partners in. And I think as well, again, similar to Sarah, the outdoor space has been invaluable in attracting BCSE engagement into the CICC. So we have a garden which men in sheds will be able to use, as well as kind of contemplation space and space for people to simply be out in the outdoors and do the forest bathing and the things that we would love to be able to prescribe that we currently perhaps don't. But also just a space that they can feel like they own, so some allotment space, somewhere that people can engage with without it feeling restricted by statutory services. So I think those are probably the two biggest lessons that we've learned there.
That's really helpful, thank you. And Frances, what's been your experience?
So I say we're quite early doors in terms of the voluntary and community sector, but what we did do right at the start was work with our organisation that provides our social prescribing locally, as they are a wealth of knowledge and they've been quite engaged in the developing our schedule of accommodation and how we want it to sort of look. I think next steps will be to start to think about what that means in terms of organisations. But yes, we want to have a mixed model of where we would have some space available, but also that, as Sarah says, how can we advertise? How can we make sure that our local population knows what is available? We also looked at directory of services, something for the future, and I think have decided actually we need to just tap into what the local authority has already done. Their public health teams have done an enormous amount of work of what voluntary and community sector organisations are available, and So I think the next steps will be to link in with that piece of work rather than duplicating. And I think that's been a lesson learned through Involve and through our local authority colleagues of it's not sustainable to do it yourself. You absolutely have to tap into what already is available, and there is often lots of available, even if it is a bit of a moving beast and changing regularly. The information out there is often very useful.
That's really helpful. I'm feeling very inspired by all of the work, and it's lovely to hear of the partnership working that's going on. We've only got 5 minutes left, which seems quite ridiculous. I feel like we've just started, but I was wondering whether we might just have a think about that. There's been a few questions come up about non-medicalizing, non-healthing space, so it doesn't feel clinical, that we're not driving it from here's a clinic. And I know I've heard all of you talk about examples, whether it's the atrium in Catterick or the open space and Sarah talking a lot about the GPs not having their clinic rooms and just going to see patients, but having a different model. And I wondered, and certainly if you're using a leisure centre space, for example, that's the less health designed space. But I wonder, Karina, have you got good examples of using space that doesn't feel so medical?
I probably don't, because of the nature of our buildings. It is one of the thoughts I had before we had this session, though, that one of the challenges for people to think about in neighbourhood health, I think, is what are the services, right back to what Sarah said at the start, what are the services you're going to be delivering, and do they require a clinical space? Because if they do, then you've got a whole long list of constraints. But if they don't, and you can do it in your local church, which we did vaccinations during COVID, didn't we, in local churches? But actually, some of the rules got relaxed to make that happen. So if it's a clinical service, you're going to need certain things in terms of the building and what you need. If it's not, and if it's something that can happen in a meeting room or a library or local authority offices, then we should be sort of working out which ones are which. And I think the building needs to respond to what you want to deliver there. So do you really need all your administrative teams in the building? Or do you need a whole lot of clinical rooms? Or what is your priority? What is the space going to be used for? And then that determines what you're trying to do. So not really an answer to your question. I think it's
still a really helpful
issue.
perspective, that, and I think it is a really interesting one. Sarah, you've talked a bit about how you've used the space for clinical delivery and other things as well.
Yeah, so we have an atrium, we call it our resource area, but it really basically is an atrium. But one of the things we did there, rather than having your standard chairs and waiting chairs, we've actually got chairs and a coffee table. And it's interesting that people were more willing to go and sit at the chairs with the coffee table than they were a normal standard chair, which was quite interesting. So we have just some chairs and some coffee tables for people if they want to go and sit in there in the day. They're absolutely fine to do it. We're just waiting, because we've only been in the build 6 months, but we're just waiting for our dementia bus stop to go up. So one of the things we looked at was, if you've got lots of people going through the building and we spent literally 2 weeks standing downstairs, making sure everyone could find the right floor. Do you need any help? Do you want us to direct you? We don't do that now. But one of the things was, we felt for our elder patients and our patients who do suffer with dementia and Alzheimer's that come into our building. So we requested for a bus stop to be put in and a bench. And if they get lost, they can go and sit at the bus stop and someone will say, do you need any help? So it didn't cost much. It was very nominal. It made the place look a bit more welcoming. We're just about to speak to the local schools to get some of our stairwells that are very big and white, to get some, I'm not going to sure what they're going to draw, but some pictures on the wall, which we will have put on some plastic wipeable sheeting, so that the stairwells are not as clinical in what they look like. If you're going to put pictures up in your clinical space, we often get asked who's going to dust them.
Yeah.
So if you put pictures up in a corridor, just remember who's going to clean them, because cleaners won't do them. So just simple things that made things a little bit more attractive.
Lovely.
We have advertising TVs and things that we put things on. So just those things.
That's amazing. Thank you. I cannot believe we've come to the end of this so fast. Such really useful. I'm hoping that people will follow up on some of these conversations. Thank you so much to our panel and the audience for participating. And thank you, Property Services, who've sponsored this event. We'd love to hear what you thought about it. So you should have an email in your inbox right now telling us, linking to our feedback survey. If you missed anything or want to share this with colleagues, the event is you can watch it on demand on our website. So if you go to the King's Fund website, you should be able to watch the event on demand. We really hope to see you at another King's Fund event in the near future. And we thank you all very much. Thank you to my panelists, Frances, Karina, Lisa and Sarah. And we hope to see you again soon. Thank you very much.